Thank you for the opportunity to speak about diagnosis and treatment of chronic thromboembolic pulmonary hypertension. My name is Farbod Rahaghi. I am a physician, a lung doctor, that is, and a researcher at Brigham and Women's Hospital at Boston, where I see patients with pulmonary hypertension and other forms of dyspnea, as well as do research in the area of imaging as it relates to pulmonary hypertension and chronic thromboembolic disease. I have no disclosures. So starting with a definition of what CTEPH, as it is called, is, part of what helps me understand and put this disease state together is trying to break apart the actual terminology that comes together to make the term CTEPH. It stands for chronic thromboembolic pulmonary hypertension. The word thrombus, or the thromboembolic part, the first part stands for the blood clots that are formed in vessels. Embolism is something that basically has traveled and lodged itself in a vessel. So thromboembolic means that it's either a blood clot that's formed in the vessel or a blood clot that has formed somewhere else and has traveled and lodged itself in the vessel. And then pulmonary hypertension, which is something that most of the listeners here are familiar with, is categorized into 5 groups, and CTEPH is considered group 4 pulmonary hypertension. It affects patients much in the same way as other forms of PH do, in that patients develop shortness of breath and exercise limitations. Sometimes it starts with some mild shortness of breath, but then it progresses further and further. And much like other forms of pulmonary hypertension, if you don't treat it, it can progress to right ventricular dysfunction. But what is different about it is really the specific treatments and time course of the disease that makes it special, and thus warrants making a separate diagnosis for it and creating its own category. So how is it actually diagnosed? Going back to what CTEPH stands for, there's the pulmonary hypertension part of it, and specifically CTEPH is a manifestation of precapillary pulmonary hypertension, meaning that the elevated pressure, the pulmonary hypertension, is a result of increased vascular resistance, and in particular arterial resistance. The arteries are flowing from the heart, from the right heart, into the capillaries in the lung, and then they flow into the pulmonary vein, then back into the left side of the heart. And precapillary pulmonary hypertension, much like group 1 PAH, manifests itself by increased resistance in those arteries on their way to the capillaries. And so we call it precapillary pulmonary hypertension. And the specific manifestations of that are the elevated pulmonary arterial pressures, but also normal left-sided pressures when you do your right heart catheterization. But in addition to these findings on right heart catheterization, which is what you would see in group 1 PH, or otherwise known as PAH, what you also need is evidence of chronic clot. And the word chronic is key here because this, as we'll see, distinguishes it from acute pulmonary embolism. So what does chronic mean? There's 2 ways to really approach that. One is to treat the patient with anticoagulation, wait a set amount of time, definitely greater than 3 months, although some would advocate waiting longer, and see if the clot goes away. And if it doesn't, then you call it chronic. But another approach is to look for specific features that make chronic clots look different, generally with imaging. And then you have to also find the clot, and that goes along with imaging. Although a key piece of it is to make sure that what you're seeing is clot and not, for example, something that has lodged itself in the arteries. One not very common, but nonetheless important case is that of tumor that has come from some distal site and gets embolized, basically lodged in the vessels, and can cause what looks like clot initially, but is in fact tumor. So this then begs the question, well, okay, what is it specifically that's different between CTEPH and PAH? As we mentioned, there are similar elevated pressures and pulmonary vascular resistances in PAH, but really, as we mentioned in the last slide, it's the finding of clot, and specifically chronic clot, that distinguishes PAH from CTEPH from a diagnostic standpoint. And there's multiple approaches to trying to get at the finding of clot, and there's three general approaches that are used often, although there are definitely other ones. One are perfusion scans, which generally are performed in nuclear medicine, where there is a tracer that emits radioactivity and is used to look at the perfusion in the lung, basically how much blood is flowing into the lobes of the lung. There's CT angiography that most people are very familiar with, where you get a CT scan, but contrast is given. And that contrast then is used to look for clot, as we'll see. And then there's pulmonary angiography that's done during right heart catheterization, where the physician, while they have you on the table for your right heart cath, actually injects dye and looks for flow in the pulmonary arteries and finds clot. And we'll see examples of this in this talk. So let's approach this then from the angle of the clot itself. You may or may not be familiar with acute pulmonary embolism. So this is a condition where a clot, usually originating in the leg or sometimes in the arms or elsewhere, dislodges and then lodges itself into the lungs, and the patient can become quite sick very quickly. It's not a very uncommon condition, actually, and patients with cancer, broken bones, especially large bones, or people who are immobilized for long periods of time can suffer from acute pulmonary embolism, and it can be quite a devastating illness initially. Once he's stabilized, most people recover, but people can get very acutely ill. And in that acute ill phase, when the pulmonary arteries are blocked by these emboli, the patient will have elevated pulmonary pressures, much like a pulmonary hypertension patient. But this is an acute condition as opposed to a chronic condition. And with clot busters, meaning lysing of the clot, and blood thinners, these clots are generally absorbed by the body and processed in matter of weeks to months and disappear. To illustrate this, these are perfusion scans, what I mentioned earlier, nuclear scans. Sometimes they're also called BQ scans because the Q stands for perfusion and the V stands for ventilation. So you get one of these that shows perfusion to the lung, and you get one where the patient breathes in a tracer, and you can see where the air is going, and you try to match the two. But this is the perfusion component. So what you're looking at are two lungs. Day one after a clot, acute pulmonary embolus, 2 months after, and then 3.5 months after, and 4 months after. These are, on one side you have one field of view, and on the other you're looking at it from the left posterior side. So it's the same person on both sides. And the white arrows are pointing to defects, meaning areas that are whiter rather than darker, where the tracer is not perfusing, it's not filling that area up. The red ones are also pointing to the same thing, except in the case of the white arrows, the defect goes away, and you can see that the whiteness, which is an area that's not being perfused, gets smaller and smaller and then is gone. Whereas in the red areas, the defect persists. And that persistence is what characterizes the presence of chronic clot. And that, coupled with the finding of pulmonary hypertension on the right heart cath, is what gives you the diagnosis of CTEPH. On the panel, to the right, what you are seeing is a perfusion scan from a patient with CTEPH. The different frames are just different times in the acquisition of the scan, where you see the tracer first appear, and then it peaks and then sort of gets washed away into the circulation. But what you can see is, instead of nice sharp boundaries for these two lungs, you have this, what is called a moth-eaten appearance, as if something is eating little wedges into the sides of the lungs. And that's something that has been characteristically described as a finding in CTEPH, although occasionally you do see it in other conditions as well, but it is highly suggestive of chronic thromboembolic disease. So I think the graphic we just went through kind of answers this question, but it's a very specific chosen example. The truth is that the relationship between acute pulmonary embolism and CTEPH is not as well as understood as we like to think when we are showing these examples. There has been a lot of studies that have looked at what happens to patients who have acute pulmonary embolus. Part of the problem is patients are right now not necessarily systematically followed, particularly if they're not symptomatic, which gets in the way of figuring out exactly what the rates are of patients developing CTEPH. But somewhere between 1 to 6% of patients after acute PE develop CTEPH. These large analyses that attempt to combine data usually put the number somewhere between 1 to 4%. But what is also interesting is that many patients with CTEPH don't actually have a history of ever being diagnosed or even really having an event that sounds like an acute PE, like suddenly one day waking up and being short of breath, or suddenly one day waking up and feeling lightheaded. They just develop gradually worsening shortness of breath. And that makes it hard to sort of connect that with one giant clot getting lodged and then failing to resolve. And there's been different numbers quoted in different studies as to what percentage of people don't really seem to have a history that's consistent with an acute PE. But the current opinion, trying to put all this together, is that this type of chronic thromboembolic disease is a result of poorly resolving clot, although it still remains to be determined whether it's results of just one large event of a bunch of clots that don't resolve, or does it require clots hitting the lung again and again and again, or does the presence of those clots then cause formation of new clots in the lungs that don't come from anywhere else? So this is part of what is still an area of active research. This is a diagram that summarizes, I think, a lot of the understandings of how CTEPH comes to be, and how you go from having a regular clot that has either formed in the lung or has come from somewhere else to CTEPH. And as you can see, in there is this concept of incomplete resolution, because in most cases, as long as you survive the initial insult and don't go into right heart failure, the clot resolves itself, and the patient, for the most part, is not symptomatic anymore. But then in certain people, for whatever reason, that resolution doesn't happen. And over time, these types of lesions build, like blockages, webs, and stenoses, and you get pressure pressure that causes shear stress in the pulmonary arteries. And so then you get some of the remodeling of the smaller arteries that you see in group 1 PH and PAH. In addition, there's been a significant amount of evidence for inflammation, the kind of inflammation that you see in group 1 PH and PAH, also playing a role. But basically, by the time this complex process is over, what you are now left with is clot that isn't going anywhere, that has restructured itself and merged itself to the wall of the arteries. And you have distal to that kind of a similar disease to group 1 PH, to PAH, where the arteries have remodeled and are not functioning very well and are thick. And so a combination of these two things and the blend of these two things creates CTEPH. To compare and contrast the two things, acute pulmonary embolus, here's two examples of acute pulmonary embolus. So what you're looking at is a CAT scan of a person with pulmonary embolus. These are their lungs, and what you see here, the white circular and long structures are pulmonary arteries. The white represents contrast. This is iodine that's been injected into the person and is inside of the CT scan as the picture is being taken. And what you see is the pulmonary artery here. So this is the pulmonary artery to the right. It's this inverted Y-shaped structure. But instead of being fully white, like this part is, you can see these long, dark gray streaks. And in fact, this piece of the artery that's coming out is almost completely filled. Here, you can see these circular arteries, and if you look in the sides, you see the contrast flowing around what looks like something that's stuck in the middle, those dark spots, and those are clots. So you can see that the contrast is flowing around these clots that are kind of lodged in the middle of the artery. In contrast, in CTEPH, what you see more is the opposite. The contrast is still wider than the background, but what you see here is that the contrast has kind of created a tunnel through this material that is now attached to the wall of the pulmonary artery. So instead of a dark spot in the middle of the contrast is flowing through a stenosis, a narrowed opening through the artery. So can you prevent CTEPH from happening? And this is, again, an area of intense research and where there's a lot of unknowns. I think that it makes some degree of common sense that if you can get rid of the clot when you diagnose someone with acute PE, that it may decrease the chances of developing chronic thromboembolic disease. But at the same time, we don't really know what causes it. So it's not clear whether the initial size of the clot or how aggressive it's treated actually prevents CTEPH. One of the things that has been described in patients who have developed CTEPH is lapse in anticoagulation. And so adherence to anticoagulation when one is diagnosed with PE, particularly when one has a recurrence of PE, is something that's very important. And we're trying to stress that to our patients to prevent CTEPH from developing. But the truth is, at this point, we don't really know how to treat acute PE in such a way other than trying to make sure that the patient remains anticoagulated to prevent CTEPH from happening. So how is CTEPH treated? There's really 4 cornerstones to the treatment. Number one, which I list at the bottom because it's the least interesting one from a show and tell standpoint, is anticoagulation, which is key. Once you're diagnosed with CTEPH, we generally recommend lifelong anticoagulation because it's basically suggests that you are prone to not being able to clear your clots correctly. So while with an acute PE, particularly if it's provoked, you may only be on blood thinners for 6 months. Generally, when you've developed CTEPH, you should be on lifelong anticoagulation. But in terms of how do you actually treat it more aggressively to try to reduce the symptoms and prevent right heart failure, there's basically 3 options. The first one, and the most powerful one, and one that has been linked to essentially curing the disease, is the surgery pulmonary thromboendarterectomy, otherwise known as PTE. And I recognize that in many sites, it's also called PEA. And that's just because you choose to sort of highlight the different letters. Instead of focusing on the thrombo, you focus on the enda and the arterectomy. And so then it turns into PEA. But you will probably see both of those notations in different places that you look. The second type of therapy is called balloon pulmonary angioplasty. And this is a catheter-based intervention, which we'll describe. And then the last type of treatment is medical treatment with pulmonary vasodilators, which many of you are familiar with for treatment of pulmonary arterial hypertension. This is a diagram by the group in San Diego in UCSD, which is one of the largest CTEPH centers, if not the largest CTEPH center, and has a significant amount of experience and leadership in developing the surgical techniques. As you can see, the treatment of CTEPH is generally something that requires a significant amount of experience and a multidisciplinary team. And this is something most experts agree with, that there's different aspects to the care of a patient with CTEPH that involves a discussion between folks who treat pulmonary hypertension and surgeons who are capable of doing the surgery. And through this process, basically, the risks and benefits of surgery, which we'll discuss in a few minutes, are weighed. And if the patient is an appropriate surgical candidate, meaning they are likely to benefit from it, and the risk isn't too high, and the patient wants to go through with it, then surgery is believed to be the best option. And if that's not the case, then the question becomes, well, what do you do? The patient is symptomatic, they still have right heart dysfunction in a lot of cases. And in those cases, then you have these options of balloon pulmonary angioplasty or medical treatment. And similarly, if you end up undergoing surgery and they're unable to take out as much material as they would like, and you have residual disease, medical therapy and balloon pulmonary angioplasty are still options available too. So what is thromboendarterectomy? It is different for sure than thrombectomy, and people get confused about this a lot. Again, going back to that picture that we looked at, a thrombus is basically a clot that's lodged in the middle of the vessel, whereas these types of clots are no longer really made out of the same material as a clot. They've kind of remodeled and molded themselves to those walls of the pulmonary artery. And so the surgery to remove these is not as simple as going in the middle of the artery and just grabbing them and pulling them out. You actually have to dissect along the plane of the adherent material to the wall of the artery in order to get these lesions out. And so it is a much more involved and skill requiring procedure to just perform it from just a technical standpoint. But then once you add the other factors to it, which is this is a open chest surgery, requires cardiac bypass, and patients with CTEPH often develop collaterals from the bronchial circulation, which is a systemic high pressure system that bleeds heavily when you're in there doing this kind of removal. And then you start with someone who basically has pulmonary hypertension and RV dysfunction. And as you may know, those are things that make surgery, any kind of surgery, hard, let alone an open chest cardiac bypass surgery. So it's a surgery that really does require a significant amount of multidisciplinary support and expertise. This is a picture of a pulmonary angiogram. So in the pulmonary angiogram, the dye that's injected, the patient in this case is receiving a right heart cath. They're laying down on a table, and there's a fluoroscopy machine, basically an X-ray, that is shining, and the dye is then injected, the contrast, and pictures are taken. And in this process, which is a pulmonary angiography, you can actually see the blood vessels, the arteries light up, Here you see a specific type of lesion that's often seen in CTEPH, and then you see that the pulmonary tree here in this lobe of the lung isn't as well perfused as the one up here. Here you also see essentially in white a web, a breakage in the flow of the contrast material. So this is another method of imaging and looking for CTEPH. But I'm showing it here to you because I want you to have an image of what the pulmonary arterial tree looks like. This is one side and this is the other. And so when you undergo a PTE, this is the type of material that they get out. And so you can see like each one of them major branches. So this is one lung, this is the right lung, and then this is the left lung. And they've gone into each of those branches and taken out this adherent material. And you can see sort of more of a reddish hue here, representing more of a central or younger clot, whereas the chronic clot is basically now white. It doesn't really have red blood cells anymore. It has more or less remodeled and is no longer the kind of thing that your body can absorb, break down and absorb. So the UCSD folks who developed this surgery initially and have written a lot of the literature on it have come up with different ways of classifying these types of lesions. And you can see that basically if the lesion involves the central arteries, you have a level 1. And as you get further and further where there isn't a lot of material in the big arteries, but you have to go very far to get anything, then you're talking about a level 4. And basically, the further out you get, the harder the surgery gets. And so in general, surgeries where you expect to see this kind of outcome, a level 4 outcome, are the risk to reward is higher, and so it has to be taken on with more of a awareness of the risk to reward. So, what is balloon pulmonary angioplasty? So, much like what they do in the coronaries, where they take a catheter, go and in the blockage, go through it and then open up a balloon to sort of squish the blockage into the walls. This is the same essential process. And what you do there is you essentially perform a right heart cath, you do a pulmonary angiography as we showed, and you find lesions and you find targets where there's a narrowing and you try to open it up. And you can treat the patient through a series of these, a lot of times requiring multiple sessions, depending on the exact type of lesions and the comfort and the specific approach of the person performing the procedure. But to go through a sequence of it, for example, you identify through the pulmonary angiography that there is a narrowing, a blockage here. You thread the catheter through the blockage, you expand the balloon, pressing the material against the wall and opening a bigger lumen. And what you end up seeing is that the venous return when you inject contrast improves. This is a reconstruction example of a patient treated with a balloon angioplasty, of course, in multiple sites along this tree. This is the tree before treatment, and this is the tree after treatment. You can see that the contrast is now filling and flowing much more freely. Of course, like any procedure, it has its benefits, which is that you don't need to have open chest surgery, but it also does have its complications like bleeding and reperfusion injury. But in the proper centers with experience, and with appropriate patient selection, we're learning that this technique can actually be a fairly powerful technique, leading to significant improvement in hemodynamics and symptoms. Lastly, there's medical therapy. And so medical therapy, in theory, targets the same thing as it does in pulmonary arterial hypertension, which is to try to dilate this, particularly the small vessels that are far away in the circulation, open them up to try to reduce the resistance. How well this works is, of course, variable, because you can imagine that if the circulation is blocked, attempting to dilate it is not going to help things too much, which is why it is still not considered the treatment of choice. On the other hand, it is a form of therapy that can lead to improvement in function and hemodynamics. Riociguat specifically was the first treatment for CTEPH that was approved by the FDA, and it works in the same pathway that eventually is targeted by PDE5 inhibitors like sildenafil and tadalafil, and ultimately leads to the same vasor relaxation. It can work in a setting of depleted nitric oxide, so there is some theoretical benefits as to why it may work better in this context. And so it was approved for this purpose and is used in patients either who cannot get surgery or balloon angioplasty, or in patients that, despite those treatments, have ongoing symptoms and evidence of persistent elevated pressures. The theory, of course, is that other pulmonary vasodilators could also have similar benefits. There are ongoing trials for some of the particularly newer agents in the PAH dimension to see if they work for CTEPH. An example is with macitentan, which has shown to improve hemodynamics and walk distance in patients with CTEPH. So to summarize a lot of what we've talked about in terms of treatment, a lot of the choice of what you treat has to do with where the problem lies, meaning, do you think that the clot is very proximal, or do you think that the clot is in the very small vessels far away from the origin of the pulmonary artery? It depends somewhat on whether you think the problem is mostly a blockage, which then is amenable to either surgery or balloon angioplasty, or do you think that at this point in the patient's evolution of their disease, that the problem is mostly remodeled very small vessels that you're not going to get to surgically or with a balloon? And so as you assess that using in different forms of imaging, largely, as well as right heart cath, you can think in terms of where the tools that we have, whether it's surgery or medical therapy, have the most impact, and then you balance that with the risks of each of these in the patient that is with you. So things that are coming down in the future of CTEPH. I think one of the more exciting and interesting parts of this field is the idea of trying to better understand and integrate the care of patients with acute PE. In a lot of centers in the Western world, PEs are treated acutely in the hospital or at home, and patients aren't necessarily screened down the road for whether they have symptoms or issues consistent with CTEPH. A lot of patients assume that, oh, I've had a big clot in my lungs, so I can't breathe as well as I used to, but that's just the way it's going to be, which causes us to lose an opportunity to catch and treat CTEPH. And so there's a significant amount of effort by groups both in Europe and the US to try to figure out when a patient presents with acute PE, what features about their imaging or about their clinical history can tell us whether they're likely to develop CTEPH. Who should be followed up to make sure they don't develop CTEPH? and to create awareness in the community that patients who have unexplained shortness of breath, instead of just treating them for asthma over and over and over again, to ask the question, much in the same way as pulmonary hypertension, could this be something like CTEPH? There is now awareness that you don't necessarily have to have pulmonary hypertension at rest for your clots, your chronic clots, to cause a lot of problems. And so a new entity is emerging called chronic thromboembolic disease. So these are patients who have the chronic clots, much like CTEPH, but if you do a right heart cath, they don't meet the definition of pulmonary hypertension. Still, a lot of these patients develop elevated pressures with exercise. Some of them don't develop elevated pressure with exercise, but have trouble with gas exchange. And so because of these issues, they then are functionally limited. And so there's been some anecdotal and case series evidence that these patients also respond to the same treatments as in CTEPH, but currently there's not enough data for any major recommendations as to how patients with CTEPH should be treated. However, I think in the future, we're going to understand better the spectrum of disease ranging from CTED to CTEPH, of what clot that is failing to resolve is and how it impacts patients at different levels. Imaging is making leaps and bounds in terms of both the resolution. CT imaging resolution is likely to improve significantly over the next 10 to 20 years as a result of a variety of technological advances. There are a number of probes that are being developed that use nuclear medicine or MRI to look at specific features of a clot to, for example, be able to tell the age of the clot, which would help us in telling the difference between acute PE and chronic PE. And dual energy imaging is allowing us to use a CT scan and contrast that we use to look at acute pulmonary embolus and CTEPH, but also get information about the perfusion. This is an example of a 3D reconstruction of a perfusion image from a dual energy CT scanner. These scanners are available now in most centers in the US and Europe that do CTEPH work and see CTEPH patients. And you can see a large defect in the upper portion of this lung. And after treatment, the defect disappears. And so you can actually see the way in which the contrast, the iodine, is penetrating the lungs, and use that as yet another way of trying to understand how the disease is impacting your patient. There is a lot of increasing experience with balloon pulmonary angioplasty. Patients are being selected now in a more algorithmic way, and centers are learning more and more how to use different types of catheters and identify targets. And as a result, the expectation is that we're going to get better at BPA, and that it's going to have a bigger role, particularly in patients who are not surgical candidates. There was a recent article by the folks at UCSD detailing some of the improvements that are now have been made over the past 20 years in PT itself. And there's a lot of different things. There's surgical techniques, there's improvements in the way we put people through bypass and partial circulatory arrest. There's improvements in treatments of pulmonary hypertension and stabilization of patients. We're catching patients earlier in their course. And so the overall result is that there's a sense in which we can use surgery to treat further and further distal disease and venture more into the smaller vessels and do a better job of removing material from them. And then with medical therapies, As I mentioned, there's ongoing trials of the different types of pulmonary vasodilators, but really the most exciting thing to me is there's a whole set of medications targeted towards group 1, PAH. The first one that is coming down the pike is likely to be sotatercept, which has had some very promising initial results that have been published. So the question then becomes, can these medications that target remodeling in group 1 disease find utility in the distal disease that exists in CTEPH that really doesn't lend itself to being operated on as well? And so that definitely is a frontier, I think, in CTEPH, although it is still many years away. Here's a list of a couple of articles that you can find online that discuss a lot of the things that were in this, as well as a couple of different resources online that you may find useful to learn more about CTEPH. I think the take-home message from a patient standpoint is that looking for CTEPH is an integrated standard part of a workup of pulmonary hypertension. And if you do have CTEPH, there's a lot of different treatment options. And usually in most regions and states or countries, there are a couple of CTEPH centers where there is a multidisciplinary team that is well equipped to both verify the diagnosis and come up with a tailored treatment plan for you if you do happen to have CTEPH. Thank you very much for your attention and for the opportunity to speak to this group. And I look forward to answering any questions in the real-time feedback session.
I spend a significant portion of my time seeing patients with pulmonary hypertension, including CTEPH. But I also spend a significant amount of my time doing research, mostly in imaging. And a large portion of that is in the progression and the relationship between acute pulmonary embolus and CTEPH. And so this is a topic that's near and dear to my heart.
It was interesting when I sent out the poster, because then I got a feedback and I said, you must have made a mistake in the poster because there's two Rahaghi presenters, and why did you copy the name? But
yes, this is probably also a question that everyone's dying to ask. Prof Rahaghi is indeed my brother. We are two brothers, and we're both in pulmonary hypertension. We work in very different places. He is based in Florida, and I'm based in Massachusetts. And I tend to focus more on imaging research, whereas Frank is more involved in clinical trials. But we're one of the, I think there's another group of PH brothers, but we are one of the two PH brothers in the world, I think.
Wow.
That I know of.
Well, it's a little bit like me. My wife has PH. It's the same as me. So we are a married couple with both of us have PH. So this is also quite unusual. Okay, so let's get started with the questions. And here's one from me. You say that one normally what, for 3 months after? Sorry, I must have mistyped here.
Yeah, no, I think I understand the question. If you want me to reword it, I think what you're asking in this question is that it takes normally 3 months for the clot to sort of dissolve, or for us to see how much of the clot is new. So our strategy generally is that if the patient is hemodynamically stable, that we basically put you on a blood thinner and see what happens in 3 months. And I think what you're asking is, well, shouldn't we remove these clots immediately because there's clots hanging out there, and could they cause other problems? That's a very good question. And it turns out that the answer is that with the very, very rare, with the exception of very rare circumstances in which there's giant holes between the two circulations, the clots that are in the lung can't actually get to the brain and other parts of the body that are that sensitive. The lung essentially acts like a filter. In effect, you're lucky that you get a pulmonary embolus, because if the clots didn't stop in the lung, they would go to your brain and you'd be immediately dead. But the lung essentially acts as a filter where the clots get stuck, because for them to go through the capillary, they would have to break up into very, very tiny pieces, which are so tiny that then they wouldn't be consequential. So it turns out it's safe for your brain anyway, for those clots to be there. The problem, of course, is if they don't go away, then you develop CTEPH.
One more question. Is imaging the only way to detect clots, or will, for instance, a blood test give an indication of a clot present somewhere in the body?
So there's been a lot of research done in this area. There are definitely biomarkers that relate to the formation of clot in the body that you can do a blood test for. The challenge is that it's twofold. One is that a lot of times these markers are also raised in inflammatory conditions. Perfect example is this marker D-dimer, which is often attested in the presence of clot. But in a lot of inflammatory conditions, the clotting cascade is also activated. And so there haven't been really very good standardized clot-specific factors that can be detected in the blood that clinically have found to use such that you would basically say, well, we don't really need imaging. But a step further to that is that the role that imaging plays in clot detection has also to do with figuring out where the clot is. And in addition, when you're talking about pulmonary emboli and CTEPH, you're also looking at the character of the clot, its distribution, and potentially helping you decide how to intervene, both in acute and chronic thromboembolic disease. So imaging at this point is very much an important part of all this. Whether biomarkers will play an ongoing increasing role, my guess is yes, but it's going to require us to better understand the genetics, the sort of the fundamental differences between clots in different stages of evolution and whatnot. But right now, imaging is still the way to go.
Okay. I guess part of my question is related to the fact that you have a newly diagnosed patient and they don't know the reason for your pH. And then I just wondered, do you need to do imaging to rule out clots, or can you through a blood test tell, yes, here is probably a clot present somewhere?
Not yet.
No,
not yet.
Okay.
It's still very much an imaging based issue, mostly in large part because you also need to make sure that even if you could tell that there is clot in the body, if the clot is not in the lung but is somewhere else, then it would still not explain why the patient has developed PH.
Yeah. Next question. Most PH patients take blood thinners. I've heard some doctors say that this is mainly due to historic reasons and that there is no strong evidence that blood thinners is beneficial for PH patients, except those that have PH due to CTEPH, plus those patients that also experience regular heartbeats. What is your comments on this?
So in the 80s and 90s, at the time where basically group 1 pulmonary hypertension, PAH, had no treatments other than in a select few of patients you could use calcium channel blockers, or you could try to treat heart failure with Lasix. Coumadin was a standard of treatment, and the idea being that there may be, and this someone, one of the audience has asked this question, maybe it's even you, later on about the overlap between PAH and CTEPH. But the idea was and is that maybe there's microclots being formed in patients with PAH, and that Coumadin could prevent those microclots from happening. There's not a lot of data to suggest that that's true. And so I would actually agree with what you have heard from some doctors, which is that really there's no proven role for blood thinners in patients with PH, except for those with CTEPH or have another indication for anticoagulation. There is a theory, like I said, there's a theoretical idea that there may be an overlap. There may be that we are not as good at detecting distal CTEPH as we think we are, but the data hasn't borne that out. And the problem with blood thinners is that they come with their own risks. And now that we have good therapies for Group 1 PH, less and less I see patients on Coumadin just for Group 1 disease.
Okay. I've heard some people think, okay, there is constriction in the lungs, and maybe if you take blood thinner, the blood is thinner and it flows easier through the lungs.
Yeah, I mean the blood thinner is a misnomer of such. It's not really, the blood thinners don't really thin the blood, in the sense that they don't alter the rheologic properties of blood. What they do is they prevent instantaneous microthrombi. So, throughout our circulation, there's tiny little clots forming all the time, just by random chance, that are then dissolving. And so that happens less. So you can imagine that you may, again, prevent that from happening. But it probably is not a very significant effect. And again, now that we have pulmonary vasodilators, to me, it seems kind of a moot point. I think at the time when this was done, there was really nothing else we could do. So, short of watching your patient die in front of you, you would sort of thin their blood and see if that helps. Yeah. But now I think we have a lot more proven therapies, and thinning, and blood thinners do come with consequences. And so we don't want to put patients on blood thinners unless there's good evidence that it's going to help.
If PH might persist even after a clot is removed due to remodeling that has already occurred, does this mean that a person suffering from idiopathic PAH might have PH due to a clot that is past resolved itself, but that the PH persisted?
That is exactly the question I was referring to in your last question, which is that this is a theoretical construct that has been proposed, and it's not without foundation. I think there's a possibility that some of the patients that we're calling idiopathic PAH have just very distal remodeling that may be related to the same disease process as distal CTEPH. It's a very good question. What I think is harder, my guess is that there are instances of this. The question is it a big chunk of the patients with IPAH? And at this point, we just don't know the answer to that question.
And then, one more question from me. Some countries have limited access to medication. Will, for instance, sildenafil be able to help CTEPH patients when riociguat is not available?
Yeah, this is a great question. And the answer is yes. So part of what led to riociguat being investigated and approved in CTEPH has basically to do with the fact that it was a choice made by the company to investigate riociguat in CTEPH. It wasn't necessarily because other drugs had been tried in CTEPH and had failed. It's just that they were the first ones to really target CTEPH as a disease process, because they felt that A, the drug would do well in CTEPH, and B, it would be a distinct market that met an unmet need, both of which were correct. However, even before riociguat was approved, many physicians had patients on things like sildenafil and tadalafil, just because these were patients who didn't qualify for a surgical intervention, and they had advanced PH. So pulmonary vasodilators in general, theoretically, can benefit patients with CTEPH. One of the two references I have in the chat box is a article from 2018 about dual combination therapy, and it was the second agent was either riociguat or one of the tadalafil sildenafil family. So it is definitely a possibility to use agents like sildenafil in CTEPH. Obviously, there's a lot more data for efficacy in riociguat, so that's our first go-to. But other agents are worth trying, particularly if there's limitations of access.
Your slides show how level 4 CTE often is not operable, but since level 4 does not represent large blockages, does that not mean that it will affect smaller areas of the lungs and hence not be as serious as level 1, 2, 3? So maybe one can live well with level 4 CTE when given medication?
Yeah, so there's two aspects. There's really like three parts to answering this question. It's a very complex question. Aspect one is that even if the disease is distal, even though these are small arteries, if they're all affected, so in other words, if it affects a very broad number of them, then you are still going to cover and block a significant real estate, if you will, of flow. And so it is not necessarily true that because these are smaller arteries that you'll have less of an impact. I mean, in fact, that's how PAH works. So what you're asking perhaps, or what's embedded in all this is, shouldn't you just get one patch of small disease? And that's a very good question. And I think part of that has to do with the mechanism behind this distal remodeling. It's not 100% clear whether the distal remodeling is just distal to the clot. So for example, let's say you have a couple of clots and you're just modeling what's distal to them, or if the high pressures or circulating factors lead to distal remodeling throughout the whole pulmonary vascular tree. And so that part also complicates things. And then you add to that the fact that it's very likely that there are people all over the world walking around with patches of CTEPH, chronic thromboembolic disease. But like you point out, it may be, only involving one patch of lung, but the rest of the lung is healthy. But we don't see those patients in clinic. So there's sort of a bias towards the fact that by the time you come to us complaining of shortness of breath, and we've done a right heart cath and you have pulmonary hypertension, and we've done imaging and you have evidence of CTEPH, you are not one of those people whose area is only smallly affected. So, we don't really know whether we're seeing a tip of an iceberg or, only people who have severe disease, or if, just like, scars on your skin, people have this kind of disease in their lung, but if it only involves a patch, then no one knows about it.
A question from Bulgaria. Do you think that patients who had COVID-19 in a more severe form can develop CTEPH?
Yeah, so this is a very, it's a very hot topic because from the get-go in COVID, it was very, very evident that patients with COVID-19 have a prothrombotic state, meaning they form clots easier than your average sick patient. And so this question of whether they develop chronic thromboembolic disease has been raised. Interestingly, there's been, for example, there was a UK study that showed that during the COVID era, the rate of CTEPH, new CTEPH cases actually dropped. So it's not, and could that be just because we're working people up less, following people up less? People with long COVID, they, think that they have symptoms because of something else, but they really have CTEPH. It's not clear. But I can tell you that I wouldn't necessarily think that the rates would be that high, because part of, at least in the Western world, patients with COVID who get very sick a lot of times either get anticoagulated or get scanned to look for clot. And so I think our awareness of the clot, the fact that we are looking for clots in patients with COVID, may actually help prevent CTEPH, because we pick up clots pretty early and we treat them. But that's just a conjecture. I think at this point, we just don't have the data to say that whether COVID-19 is going to lead to a rash of patients with the chronic thromboembolic disease. But I think, the cornerstone of preventing chronic thromboembolic disease is anticoagulation and prevention of recurrent clots. So hopefully, if you've been diagnosed with COVID and you have severe symptoms and shortness of breath, someone will look for clots and make sure early on in the process so that you don't develop CTEPH.
Another question from Bulgaria. Can you provide more information about perfusion scan? What kind of specific information does it give to pulmonologists and cardiologists?
Yeah, so a perfusion scan basically tells you, it gives you a geometric representation of both lungs and tells you where the blood is flowing. In a normal lung, the blood should be flowing uniformly throughout both lungs. In an abnormal lung, the blood should be flowing in the areas that are not abnormal. So let's say if you have severe emphysema, then you can also do what's called a ventilation scan, and you see where the air is going. And then you get a perfusion scan, and it shows you where the blood is going. And if the blood is not going to the same place that air is going, then what you have is a ventilation perfusion mismatch. Now, what can cause that? Something blocking the arteries. And so it's a way to detect blockage and thus a way to detect clot. The use of perfusion scans has largely been supplanted by CT angiograms, although this is still a major debate for CTEPH. There is still cases we have seen where CT angiography doesn't pick up chronic thromboembolic disease, but perfusion scans do. But with improving a resolution of CT angiography, this is becoming less and less of a common occurrence. And so perfusion scans are largely used now either in very high suspicion CTEPH cases where you really, really want to rule it out for sure, or as a complementary piece of information, particularly if the patient's kidney function prevents you from getting a giving contrast. But the official recommendations from different societies still, a lot of them recommend using perfusion scan as the absolute most sensitive test to look for chronic thromboembolic disease.
From Slovakia, what is the success rate of PTE? How long does it take? How long does the recovery take?
Let me answer the second part first. The recovery, it depends on what stage of recovery you're referring to. The inpatient period can be as short as 4 or 5 days or a week. The sort of getting back on your feet and being able to do things has a lot to do with your other comorbidities, your age, how much, how sick you were before the surgery. But it can be on the order of weeks to a month or two. In terms of how long will it take for you to get the maximal benefit, that can take many months. But a lot of patients who undergo surgery were feeling pretty bad before the surgery. So there's definitely a significant majority that start feeling better fairly quickly after they go home and recover a significant amount of their function. Now, getting back to the biggest bigger question of success rate. So this is a very complicated question because it depends on how you define success rate, and the other part it depends on is where you're getting your surgery. So I have put in the chat room another reference to a paper by Dr. Madani. So the PTE surgery itself was the most experienced center in terms of developing it and really building the data behind it and the technique is University of California, San Diego. And Dr. Madani is currently leading their group. And the paper that I've posted there is a sort of a summary of their current experience with the surgery. And it has some numbers and things of that nature, including, people who have been taken back for second PTE and other things like that. The data clearly suggests that the more experienced center you are, the higher success rate you have. It also suggests that the more proximal clot and burden you have, the more successful the surgery is. And then once you dig into the question of what is success, there is this centers quote as much as 90 to 95% quote unquote cure rate. But then if you really dig into it, what does cure rate mean? Cure rate can mean that you no longer have CTEPH, you no longer have pulmonary hypertension, meaning if I do the right heart cath on you, your pulmonary pressures would be below the cutoff. But does it mean that you're totally normal? Does it mean that you can run a marathon now? Not always. So, it can get very subtle. And so I think as you start, if you have a tremendous amount of proximal clot and you go to an experienced center, I would say that, there's a greater than 95% chance that if you qualify for a PTE, you are going to improve your well-being significantly by having the surgery. On the other hand, if you have very distal clot, you already don't feel that bad and your right heart is functioning okay, and you're going to an inexperienced center, there's a much lower chance that you're going to get benefit from the treatment. And so I think, in the olden days, you talked about cure. I think people are realizing more and more that, it's always a continuum. You're always improving things. You're not, it's not like treating an infection where you take the antibiotics and then there's no trace of it, 5 days later.
Yeah. We have the case in Europe. I think it's in Ireland, the swimmer who had CTEPH, and then he had an operation, and afterwards he swam across the channel.
No, and absolutely. And there are definitely cases like that. And in fact, a lot of the data, again, from UCSD suggests that that's a large portion of the patients. But again, I think part of it is also now that in the past, they were not operating on a lot of patients. They would say, oh, your disease is too distal. So now that we're trying to treat people who are harder to treat, it may also be that so I think it's really about picking a good center that does this, and specifically asking the question of what's the likelihood my personal disease is going to respond to the treatment that you guys have experience providing.
Finland, what situations can be performed balloon angioplasty catheterization? Can this performed many years ago when clots came to vessels? I don't know. Do you understand the question?
I do.
Okay.
So balloon angioplasty can be used anytime based on imaging, really. You see that there is a narrowing of the pulmonary arteries that is happening in vessels that are large enough to be accessed by catheter, which generally means, third generation, fourth generation vessels that you can get pretty small, but not super small, not micro vessels. And in theory, they can be done in any type of CTEPH. What has prevented balloon angioplasty from being a lot more widespread is the fact that the surgery has, in the right hands, been pretty good at removing the material and having very high success rates. So the recommendation still stands that if you can have the surgery, meaning if you have access to qualify for and want to have the surgery, that you should have the surgery. But there's a lot of people who don't qualify for the surgery because they have too many comorbidities, or don't want to have the surgery because it's high risk, and or they're old, or they don't have access to good surgical centers. And then there are people who've had the surgery, but they were only able to partially treat the problem. So there's a myriad of conditions like that where balloon angioplasty can offer a significant improvement in hemodynamics. And in terms of timing, yes, the balloon angioplasty can be done anytime in the disease course, as long as the clot is chronic. An acute clot, if you try to inflate a balloon, it'll just dislodge the clot. But in chronic clot, the clot is already adherent and has worked its way into the walls of the vessel. It's no longer really a clot, but rather more of almost a scar. And it doesn't matter if it's 2 years old or 5 years old, or that we know of. We can try to expand the vessel and push the material out of the way to improve flow. And so generally what this procedure involves is a bunch of attempts to go and find these narrowings and open them up.
Finland again. Can marijuana dissolve clots, or is it what is the name of this? Clisane or something? Is the better?
Yeah.
Is the newer buttoning medication?
Yeah. So there's very little data in terms of superiorness of any blood thinner to the other. And when I say that, I want to qualify that by saying that part of it is that no one ever designs superiority trials. It's not to the pharmaceutical company's advantage to do that. And so what all of the companies do when they introduce new blood thinners is they design it to show that it is not inferior to warfarin. And so as far as we know, the blood thinners are all at least as good as each other, if you will. But what we don't know is if any of them are actually a little better than each other. That is, the studies are not powered enough or designed to tell subtle differences in that level. And then when you take that to the next level, which is that, the CTEPH patients are a small subset of the patients out there, there's not a lot of large data sets that would answer questions, particularly ones where you compare people head to head, or any that really assign patients to two different blood thinners to see which one does better. Generally, these studies just look to make sure that the rates of really bad events are the same. And they tend to be. And so we feel like you can use different blood thinners in different contexts. But a lot of the CTEPH centers still say that the most amount of experience is with warfarin. And so still there are many people out there who recommend warfarin because we know the most about it.
I've also heard some that are a little hesitant to go on the new blood thinners because they say that with warfarin, if your blood becomes too thin, you can give vitamin K and it will thicken it. But with the other ones, it will take time to get the blood thin again.
That is correct. Although extremely expensive, but nonetheless available antidotes to some of the other blood thinners are now available. Okay. So there are going to be, that's going to be less and less of a problem. But you're absolutely correct that reversal is always an issue, because if you're in a bleeding situation, it's good to be able to get control of that very quickly.
Yeah. Austria, how much time passes on average until CTEPH maybe is formed after a PA?
You would be surprised how little we know the answer to that question. And part of it is that a lot of times patients with PE are not followed after PE. And a lot of times patients with CTEPH, and as much as 50% in some of the studies with CTEPH, have no history of PE. They can't even tell you that there was one day where they woke up and they were more short of breath. the disease has set gradually. So the truth is we just don't know. What we do know is that most of the clot that is acute should dissolve on blood thinners on the order of 3 to 6 months. And so what we do, practically speaking, is when we see someone with acute pulmonary embolus, if there's residual disease after 3 to 6 months, depending on who you ask, we start thinking of that clot as chronic. And so that is unfortunately, part of the lack of data that we have in terms of the natural history of this disease. But there's a lot of large research studies that are starting and ongoing to try to better understand this question.
Spain, is the same treatment used for CTEPH when it is caused by a clot as for an acute episode of pulmonary embolism?
This one I had a little trouble understanding, in the sense that I think if I understand the question better, if I understand the question, in terms of blood thinners, yes. In terms of blood thinners, we use the same blood thinning strategy for CTEPH, because currently acute episode of pulmonary embolism, the treatments for it are either mechanical interventions, clot busters, or blood thinners. So the only part of that it shares with CTEPH is the blood thinners. Now, the other things that you can do for acute pulmonary embolus, like clot removal, excuse me, are different than the ones in CTEPH. So the surgery for CTEPH is a much different surgery than what you would do for an acute clot. You can also open the heart, the chest, and the pulmonary arteries and take out clot. But doing that is actually a much simpler surgery than what is needed for CTEPH because of the way that the clot is adherent to the walls of the arteries. And so it's basically, the answer is no. Other than blood thinners, we don't use the same treatments. Excuse me 1 second. I needed a water break.
Okay. So does surgery to treat CTEPH work in all cases?
Yeah, so the answer is not in all cases, but I would say in most experienced centers, the numbers are in north of 95%, in the sense that a significant amount of clot is removed and the patient's hemodynamics is improved post-surgery. Again, to the extent that you define what is cure, is it swimming across the English Channel, or is it, being able to not be in heart failure? That's a deeper debate. But most patients who undergo surgery benefited. But part of the reason for that is that patients are very carefully selected for surgery. In part because these centers are very acutely aware of their success rate. And so they don't want to take people to surgery who are going to do worse after the surgery. And so, usually the decision to go to surgery involves a multidisciplinary discussion that involves cardiologists, pulmonologists. There's a lot of imaging that's done. We talk about these in conferences. So it's not a surgeon coming down to the emergency room and, getting consent from you and they take you up to the OR. It's a process that involves a lot of discussion. And I think and if you talk to the folks at UCSD, and I had the chance to go around with them and see how they do things, a lot of it has to do with the multidisciplinary care before and after the surgery as well. So it's a very complicated process, and that's part of the reason it's so successful, is that patients are carefully selected and then neatly cared for by super specialists before and after the surgery.
And I guess it's like you say, you need to be an experienced center to do this. And like in Norway, we are so few people that I know they've been discussing maybe they should collect all the patients in Scandinavia together in one center instead of having smaller centers in each country.
I think, you know, I'm not trying to be, you know, exceptionalist or whatever that term is for what I may sound like, but I think there is very good data and good agreement amongst everyone that experienced centers for CTEPH are very important. You know, that they're important for pulmonary hypertension as well, in general, so that people have, you know, have an awareness of the different subtypes and whatnot. But when it comes to CTEPH, the surgical experience and the experience of selecting patients and taking care of them during and after surgery is crucial to the outcomes.
Right.
And the problem is experience comes out of numbers. And, you know, there's only so much intelligence can help you. At the end of the day, you need numbers.
Yeah.
And so that you know, I think that's a very good discussion to have in terms of how do you gather enough patients in one place so that you have and gain that much experience.
Question number 15 from Spain. I would like to know if data has been contrasted or from your professional experience on what efficiency of improvement in patients with thromboembolic hypertension with a drug treprostinil for CTEPH. We have heard that it is treprostinil especially designed for this type of patient with chronic thromboembolism belonging to World Health Organization functional class 3 and 4.
Yeah, we've certainly used advanced therapies, IV therapies for patients with inoperable CTEPH who have class 3, class 4 symptoms. And so I think it's a very reasonable therapy. Like I mentioned, all pulmonary vasodilators have the potential to be beneficial just because they decrease pulmonary vascular resistance. In terms of, I personally and don't have any, and nor do I really know anyone. Unfortunately, I'm a US-based practitioner with the drug Tripolmix. My understanding of this medication is that it's treprostinil, but it's specifically formulated in specific dosage levels, potentially to make it easier to use in CTEPH. I can't tell you that I know that it's more efficacious than IV treprostinil. It's hard to know without a direct head-to-head. It's much like the warfarin and other anticoagulation debates. I think it's certainly a very reasonable thing to use to treat CTEPH.
Hungary, about what percentage of the patients need medical therapy even after the surgery?
So again, that all depends on who is doing the surgery, in part because a lot of centers that don't have a lot of experience, they don't take patients with distal disease to surgery. So then all those patients who they don't take to surgery go on medical therapy, whereas other places will take a lot of patients to surgery, give it a shot, and then if it doesn't work, then they put them on medical therapy. So there's no hard and fast number for that, but you know, some of the literature talks about 10-20%, but you know, it all has to do with how distal your disease is, and so if they take you to surgery for distal disease, there is a good chance that you may still need some medication, although less of it, or have better symptomology on medication. But you know, I would discuss that really with the center that you're considering.
Another one from Hungary. Can it happen that new clots make new restrictions after the surgery, or someone can only have residual CTEPH because not all parts of the restrictions were successfully removed?
Definitely. So there's definitely cases where they were not able to get a lot of the material out or enough of it out to lead to hemodynamic normalization. Now, new clots, the reference that I put up there, the one from Madani from UCSD, actually discusses that a little bit. They have about I think 40 or so patients who needed a repeat surgery, and they specifically mention in there what the causes were. And if you look at it, a lot of it has to do with having come off of blood thinners, either because of lack of compliance or because patients developed a lot of bleeding. So at some point, someone decided, it's better for them to be off blood thinners and take the risk of developing CTEPH again, and they did. So I think, while it's possible that you could form clots despite being on blood thinners, and it definitely happens, for the most part, we believe that most recurrence of CTEPH after successful treatment has to do with not being sufficiently anticoagulated.
What should the ENR level be, by the way, in order to be sufficiently
Yeah, I mean,
protected?
there are places that talk about INR that's closer to 2.5, but we still practice under the 2 to 3 range,
Okay.
above 2.0.
Slovenia, is the patient more susceptible to new ones after the clot are removed, for instance, after suffering from COVID and vaccination?
This is also a topic that is not well understood, whether the arteries that have been acted upon are more susceptible to new clot formation. I think we don't know the answer to this. I think but the data does suggest that if you remain anticoagulated after your surgery, that you're fairly well protected. So I wouldn't not get the surgery because you're worried that it'll put you at the risk of more clot. I think that at the end of the day, the best protection against that is anticoagulation.
Bosnia and Herzegovina, is there a higher number of patients with CTEPH as COVID infection consequences? I guess you answered this partly before.
Yes. No, we don't know yet because we don't have the data, but at the same time, it may be that the chronic component is being offset by the fact that we're also looking for clot in patients with COVID early on.
Another question from Bosnia and Herzegovina: how to recognize and react to consequences which are displayed later, as SARS-CoV-2 infection results? Are there any new methods of diagnosing?
If I parse this question correctly, I think that the answer is not really. The way we would think about this, particularly in the context of COVID, is when you get your COVID infection, you get a lung infection, and that lung process with the low oxygen and all that sort of runs through its course. And if at any point we see something that doesn't match the disease course, we start worrying about you having a clot. Or if you recover from that lung infection and you're still, showing a shortness of breath or low oxygen levels or evidence of pulmonary hypertension, we also worry about clot. And at that point, our go-to diagnosis is still imaging. And so that would just raise our index of suspicion to look for a pulmonary embolus. We would put you on a blood thinner. And then if the blood thinner doesn't do anything substantial to the clot, then we start thinking that it's chronic.
I guess also the newest mutation of COVID, I've heard that it does not go to the lung as often as the older mutations, and that you don't have the same lung problems.
That may be true, although, again, we don't know if that's true of the clotting problem. Because the clotting problem may be unrelated to sort of what it does to the lung alveoli. It may be that its effect on the inflammatory system is what's driving the clots. So I don't know if we know the answer to that question.
Belarus, what combination therapy is currently indicated and has a result in CTEPH?
Yeah, so I one of the 2 articles I posted is actually one of the few papers that looks at combination therapy. I think that the general wisdom is, because CTEPH is it's a small disease within a small disease of pulmonary hypertension. So it's not like there's thousands and thousands in each country. And so there hasn't been a lot of data, looking at, different types of combination therapies. But the general wisdom is that pulmonary vasodilators have good evidence, either anecdotal or in small studies, of working in CTEPH. And so there is some data about upfront combination therapy in CTEPH, and as we've mentioned, drugs like treprostinil and even advanced drugs in CTEPH have been tried. The challenge is really that at the end of the day, the data hasn't really compared, for example, dual combination therapy versus surgery, because the general data that we have available to us still suggests that medical therapy should be reserved for inoperable cases or cases where operation has happened and there's still residual disease.
Last question. What is the percentage of the return of pH after the removal of blood clots?
And like I said, this really has to do with the surgery, the disease, and but particularly using resting pulmonary hypertension as a bar, I would say a lot of centers are saying that 90% of patients don't have pH after surgery, or even 95. So the odds are good that if you undergo surgery at an experienced place, that you will no longer have pH. But again, does that mean you're completely cured? And does that apply if you have difficult to operate on disease? That's really the question.
Okay, well, thank you. That was the last question, and I now know it's soon 10 o'clock in the morning for you. And as I've heard, and you've been up all night in the hospital, so now it's bedtime for you, I guess. And we really appreciate that you took your time, and we are really lucky to have such a prominent professor as you to take your time to give us your presentation and answering questions. So thank you so much.
And I'm very happy to do it, and thank you for organizing all this and giving me the opportunity to talk to people who are, all the questions you guys are all asking are extremely on point and very, very probably harder than a lot of the questions I get asked in scientific meetings. So thank you guys for all your interest, and best of luck.
Okay, thank you. And for the viewers, now we will talk to the brother. So that will be in just a few minutes. Thank you.
Take care.
You too.